Well, welcome everybody. Thank you so much for joining this webinar today. And this webinar is being brought to you by the Aphasia Committee of the IALP, as well as co-hosted by the Centre of Research Excellence in Aphasia Recovery and Rehabilitation. My name is Miranda Rose, and I'm a professor at La Trobe University, but I'm also the director of the Centre for Research Excellence in Aphasia Recovery and Rehab, or the Aphasia CRE. So today's seminar is about providing evidence-based, person-centred aphasia rehab. And in particular, what I want to focus on is all the amazing resources that are now available to us to help us implement evidence-based aphasia care. So let's get going. So before I go too much further, I'd like to acknowledge that at La Trobe University in Australia, I work on the lands of the Wurundjeri people. This is the First Nations people who are the traditional custodians of the land here. And I'd like to acknowledge that the land that we are working on was never ceded, and to pay my respects to the elders past and present, and particular a welcome to any First Nations people joining us today for the webinar. Just a small amount of housekeeping before we dive into the overview of today. In this webinar, you'll see that there is a Q&A function, and you're very welcome to put your questions into that Q&A function. And hopefully today what I'll do is speak for about 50 minutes, and then we'll have time at the end to address at least some of the questions that come in. Please don't use the chat function for your questions, and please just put questions in rather than comments. That would be really helpful. Okay, so what am I hoping to cover with you today? First of all, I'm really hoping that participants in this seminar will feel motivated and confident to design aphasia rehab that can address all the components of the WHO ICF framework. So that is goals beyond simply language impairment and even functional communication, which I think have become very commonly used across the world, but to also consider general participation in life, mental health and well-being, and environmental factors that impact the way in which communication is enacted. I'm hoping you'll also feel confident and motivated to tailor aphasia rehabilitation programs to your clients' specific needs, and to be able to locate evidence-based resources to support your practice. So the way in which we'll get through that goal today is, first of all, to focus in the first section on general approaches to aphasia rehab. So thinking, as I just said, in terms of the objective, about how aphasia impacts the individual way beyond language impairment and even communication disability, but more broadly. And then how we need approaches that enable us to tailor person-centered care and to develop goals in a broad spectrum, so across language and communication, activity and participation, mental health and social relationships. And very importantly also, to think about the central role of family members and care partners in aphasia, and the need to include these people in our rehabilitation programs. In the second section of the seminar, we'll focus on resources that will enable you to carry out evidence-based comprehensive care. And I'm really happy to say that there is just too many resources available in the world now to cover today. So the ones that I've chosen to focus on cover a range of domains of the International Classification of Functioning and Disability, or the ICF, and across multiple domains. So we'll go through these one by one. Okay, so let's get going. In terms of approaches to aphasia rehab, the sort of classic dichotomy that most of you would be familiar with is a kind of biomedical model versus a biopsychosocial model. So just want to be clear what we mean by this. In those of you that were educated some time ago might know that the biomedical model was pretty much all we were exposed to. And in that model, the idea is that the model of healthcare focuses on the underlying impairments or dysfunction in body systems, and diagnosis focuses on identifying those physical symptoms that are impaired. And then the interventions are designed to overcome and change those damaged systems. And this kind of approach, almost a mechanical approach, has dominated medical care in acute systems, forever really, and continues to dominate a lot of what we see in acute stroke rehab and in aphasia care. Some time ago, in around 1977, an American psychiatrist and physician named George Engel really questioned the utility of the biomedical model and started asking questions around the impacts of other domains of humans on well-being and health and response to illness. And so he started to say that, we really should be including psychological, social, and environmental factors when we're considering the impacts of disease, and also that these should be direct targets of interventions in order to achieve better outcomes and well-being. And this was the birth of the biopsychosocial model. And a very common rendering of this is the ICF the WHO ICF that those of us who trained more recently would have been schooled in. And in this model, the idea is that a person's level of functioning is a dynamic interaction between their health conditions and environmental factors and personal factors. And together, these create the experience of wellness or illness, and integrates concepts from social and medical models of disability. A really fantastic rendering of the ICF has been available for quite some time from our colleagues from the Aphasia Institute in Canada, the AFROM. And this was co-designed with people with aphasia because the ICF was not seen as being particularly communicatively accessible. It was difficult for people with aphasia to understand the ICF. And so people at the Aphasia Institute worked with people with aphasia to re-render that into a more understandable design. And here you can see the impact of the intersection of your aphasia, the environment, personal factors, and participation opportunities and experiences to intersect to create your life or quality of life. And this has been a really useful framework for many people who are designing rehabilitation programs that take into account the whole ICF. And it's also the underpinning of an approach to aphasia management called the life participation approach. In the life participation approach, the goal is enhancement of life participation. So rather than communication being the goal, it's life participation. And in this approach, everyone affected by aphasia is entitled to services, and success is measured by documented life enhancement changes. So both personal and environmental factors are intervention targets from this approach. And there's a strong emphasis on availability of services across the lifespan, so across all stages of aphasia care. If you'd like to learn more about the life participation approach to aphasia, there's some fabulous educational videos about it available through the wonderful organisation called Aphasia Access. And you can go to their website and learn more about accessing a whole range of resources, but their live participation education videos are fabulous. So, we've learned a little bit now in terms of some general biopsychosocial approaches, including the life participation approach. But why do we need these in aphasia? Why is it just so vital that we take this kind of approach when we're considering rehab for aphasia? Most of you would well know that aphasia is a lifetime communication disability for a large number of people. In fact, it's estimated that 50% of people after a stroke with aphasia still have significant communication problems 1 year on after stroke. In Australia, we know that there are about 140,000 people living with aphasia, so this is a quite common disability, and that is more than the combined number of people who are experiencing Parkinson's disease and multiple sclerosis. So it's quite a common disease. And in the USA, that's estimated to be, more than 2 million people. The rough population estimates are about 0.4% of a country's population. So, this is not a rare condition. It's a common condition, and we need to be able to provide services to a broad and large number of people across the globe. We know that aphasia compromises almost every aspect of daily life, and it's particularly heavy on relationships, negatively impacts relationships. We see that people with aphasia lose contact with friends across time, and this has a devastating impact on social well-being and mental health. We know that people with aphasia have extremely low rates of return to work and therefore reduced income, and the added problems that are associated with financial insecurity. And health-related quality of life is documented as being very low, even compared to very common and many other common medical conditions. And when people can't communicate well, they often struggle then to engage with healthcare services. So not just during the recovery from the original brain injury that caused aphasia, but from every moment going forward when the person's trying to get any sort of health care. We know that aphasia has very negative impacts on mental health, and the prevalence estimates are about 4 times the rate of depression compared to the general population, and approximately twice that of people with stroke without aphasia. So very significant amounts of depression. And there are similar rates of anxiety also documented in people with aphasia. But it's not just the person with aphasia that is impacted by aphasia. It's also family and friends. And a recent study by Swedish colleagues looked at burden and stress in caregivers, and they found that 80% of their sample had stopped work or had reduced work hours. About 80% reported reduced leisure time. There was reduced social interaction and worse psychological health. So all very significant impacts of caring for someone with aphasia. So if you think about those negative sequelae that we've just summarised, it just seems so obvious that we need a biopsychosocial approach to manage the broad impacts of aphasia. And I just don't think it's can be disputed that we need to think beyond language and maybe even beyond communication. So what have we got that we can use to guide our practice in this area? Well, one of the things we have are some guidelines, clinical guidelines, and synthesis of clinical guidelines. Back in 2017, a team of researchers, and I was one of those team members, led by Nina Simmons-Mackey and Linda Worrell, came together to try to generate the top 10 best practice recommendations for aphasia. And what this group did was look at the evidence from published clinical practice guidelines that were available, and then went through a consensus process and an expert panel to come up with the top 10. And this involved more than 500 speech pathologists across 10 countries in the consensus process. I'm going to go through those top 10 now because I'm hoping that they're going to stimulate some of you to think about auditing your practice on them. The first is to screen all patients for communication deficits that present to hospital. And those with deficits need to be assessed by a speech and language therapist. People with aphasia should receive education and information about aphasia, and no one with aphasia should be discharged home without a means of functional communication or a plan about how that would be achieved. People with aphasia should be offered intensive and individualised therapy designed to have meaningful impact on communication and life. Communication partner training should be provided. Families should be included in aphasia rehabilitation. Services should be culturally appropriate and personally relevant. And all health and service care providers should be educated about aphasia and be trained to support communication. And the 10th best practice statement is that information intended to be used by people with aphasia should be in aphasia-friendly formats. These top 10 best practice statements were translated into a range of languages. In fact, about 25 languages, I think. And so you can access those translated versions for those of you that are interested in looking at them outside of English by going to the CATS website through the QR code or the website address there. So more recently, a team led by Sarah Wallace and Bridget Burton updated this review that we had done back in 2017 to look at stroke clinical practice guidelines to inform aphasia management. And they identified 9 clinical practice guidelines that met quality ratings. And from there, they determined that there were 82 recommendations for best practice. And they created a really beautiful infographic that's in the journal article that summarizes those 82 best practice statements, starting with screening communication and then assessing and documenting the impacts of aphasia, providing accessible information, responding to diversity. So this is the issue of making sure that the aphasia intervention is culturally and linguistically appropriate. They included a category of setting goals together, which was not in the original 2017 top 10. So the idea that goal setting should be done collaboratively. Providing speech and language therapy intensively as tolerated. Providing communication and partner training to family and friends. Importantly, monitoring mood, and this was another of the categories not in the original top 10. Connecting and reintegrating, so making sure that information about support and community resources were offered before discharge. And supporting safe discharge, so making sure that patients had a comprehensive discharge plan that was able to be understood by them. So this is a lovely infographic. The central element there is around making sure that the care is organised in an interprofessional space, and that, of course, all people working with aphasia would be educated about aphasia and about how to support communication. And finally, in this best practice sort of space, just recently, Kirstine Shrubsole and Sarah Wallace led a team around looking at what quality indicators could be determined to enable us to check whether these best practice statements were being implemented. And I won't go into this in great detail, but it's a lovely piece of work bringing together the perspectives of consumers, so people living with communication disability after stroke, and health professionals and carers. And they, again, came up with 10 best practice statements, although out of the 23 they looked at, overall, the respondents all really thought these recommendations were important. They then went on to identify quality indicators and finally identified 3 implementation priorities. And those priorities were assessment of aphasia, provision of aphasia-friendly information, and provision of therapy for people with ongoing goals across time. So if you had to choose, 3 of the 10, this work would suggest the focus on those 3. So if we think about this notion of best practice statements and trying to move our practice forward, you might consider auditing your practice or your service using these best practice statements. So identifying, what are you doing well at the moment in your service, what's missing, and what you might do to plan to address those gaps. So I hope you'll take away some of that work and do some reflection in your services about that. Okay, so we've covered off an introduction where we've looked at the biopsychosocial approach as being essential in aphasia recovery, and we've talked about some best practice statements to guide our focus. And now I'm going to focus for the rest of the talk on some resources that would enable you to carry out those plans. And I'm going to first of all direct you to the Australian Aphasia Rehabilitation Pathway. This is a comprehensive repository of best practice statements and resources that was originally made available in 2013, led by Professor Linda Worrell from the University of Queensland and a team across Australia, with involvement from clinicians and people living with aphasia. Most recently, a group that I led here through the Aphasia CRE updated the best practice statements to take account of the evidence, that fantastic amount of evidence that had been published between 2013 and 2024. And if you go to the website, you'll be able to find the updated best practice statements. The pathway is divided into 8 main sections, so receiving the right referrals, optimising initial contact, setting goals and measuring outcomes, assessment, providing intervention, enhancing the communicative environment, enhancing personal factors, and planning for transitions. So already you can see some of the wording there lines up with the WHO ICF and this kind of broad spectrum of care that we need to provide in aphasia rehabilitation. The document that is the best practice statements that you can download from the website has those 8 sections, so from receiving the right referrals down to planning for transitions. And we have 86 best practice statements in this document. And we list all the evidence behind those statements and then link to some resources. So as an example, if we go into the setting goals and measuring outcomes portal, we'll get directed towards person-centered goal setting. Now, just to revise in case people are not really clear about this, there's good evidence that person-centered goal setting is a highly effective method of improving patient outcomes in stroke in general, but in many areas. And it's recommended in many of the international clinical guidelines that you would be looking at. And in person-centered approaches, clearly the clinician explains and supports the process of goal setting, but the patient maintains full ownership of those goals. And evidence suggests that many stroke survivors are just not invited into a personal goal-setting experience. And in particular, people with aphasia are frequently excluded from goal-setting processes altogether. So we really want to find ways to overcome this exclusion by providing resources to enable this to be an easier, more inclusive process. So in the Australian Aphasia Rehab Pathway, we provide descriptions of this client-centred goal setting process and then link out to resources. So the first framework that people are suggested to use is that was developed by Deborah Hirsch back in 2012, the SMARTER framework. And the SMARTER framework was amended from the SMART goals framework, which is a well-used and understood framework of specific, measurable, attainable, realistic, and time-based goals, to be more inclusive of people with communication disability and to be more across notions of the ICF broader goals. So they need to be shared, monitored, accessible, relevant, transparent, evolving, and relationship-centred, so SMARTER. I don't have time today to go into the depths of that framework, but it's a really helpful framework for goal setting. And one of the lovely resources that are available to help those of you that are less familiar with it get familiar with it and to enact it is a free resource available through the Tactus Therapy website, where you can download a comprehensive guide to setting goals that has some supports for communication access and thinking broadly about goals. So I really recommend that to you. So moving on from setting goals, we're now going to talk about some intervention resources. And the first one is the Aphasia Therapy Finder. So the Aphasia Therapy Finder is a searchable database of resources that aims to bridge the evidence-practice gap and help in the selection and implementation of evidence-based aphasia therapy. It, at the moment, includes 25 aphasia therapies, and these were selected according to their levels of evidence. So we wanted things that had trial-based evidence or meta-analysed evidence to support their effectiveness. And you'll see here a long list of the 25 therapies. I won't read them all out, but many of these are commonly used in aphasia practices across the world. And some of them are less commonly used, but are highly effective. And so we wanted to try to help people be able to implement them by linking people to descriptions and resources that would support enactment. So you can log on to the Aphasia Therapy Finder. It's a free website. You just need to provide an email address and a password. And then once you're logged on, you'll see the 25 therapies are listed as little tiles, and you get a level of evidence summary and a brief statement about them. And you can search manually or through the filters that exist on the Therapy Finder. So by level of evidence, by the target of intervention. For example, you might want to work on communication or mood, by what linguistic level you're focusing on, for example, word or sound level, what ICF domain you might want to target, for example, personal factors, or modalities, for example, reading, writing. And here's an example from MMAT, multimodality aphasia therapy, where a summary statement is provided, and then you can flip down and open up the drop-down menus to look at levels of evidence, therapy targets, therapy ingredients, proposed mechanisms of action, and the resources. So here's the statement, here's the rationale for the level of evidence with the links to the relevant journal articles, and then a description based on the ICF domains, targets, what sort of clients might be suitable, and then links to the actual detailed therapy protocols, and then a very detailed description of the therapy methods, links to the materials, and including video examples of the therapy being executed. So we hope these kinds of levels of detail, which used to sit within, academic journals or perhaps in the filing cabinets of the researchers and clinicians who'd been undertaking the study, are now out in the open and more available for therapists to be able to explore and practice and enact. So yeah, 25 therapies that you can explore there, and we hope to bring more out very soon. Okay, so recently, the issue of dose and intensity and frequency has been raised in work. In other words, how do we get the right dose and intensity of intervention to make the therapies that we are given actually effective? I was involved with the release collaboration. This is very large-scale work undertaken and led by Professor Marion Brady and Ali Maizoun from Scotland. And in this work, we analysed 959 individual participants that were derived from 25 different quality randomised controlled trials and other sorts of trials. And what we found in that work was that the greatest overall language gains that we saw in this data were associated with doses of around 20 to 50 hours of total therapy, given at 3 to 4 hours per week for 3 to 5 days per week. And also that the best gains were seen after functionally relevant tailored therapy and home practice. Importantly, in that analysis, it was highlighted that there were very limited gains demonstrated in the domain of auditory comprehension for doses less than 20 hours, less than 3 hours per week, and less than 3 days per week. So if we're aiming for this 20 to 50 hours, 3 to 4 times per week, 3 to 5 days per week, we know that most people with aphasia just do not receive this kind of dose. And so there's a question about whether some of our interventions can get to be effective unless the dose is increased. And one way that we can think about increasing dose is to increase the amount of self-management and self-managed practice that a person with aphasia might be able to undertake. So if a clinician isn't going to give all this intervention and you need to try and find tech solutions to support that self-managed practice, you need to know, well, how am I going to find that? And so the Aphasia Software Finder is a tool that might be very useful to you. The Aphasia Software Finder was funded and is run by the Tavistock Trust for Aphasia. And in this website, you can go and search for the kinds of software that might be relevant to your client. So aphasia apps or general apps designed for aphasia. And then you can look at, what domains do you want to explore, talking or reading, for example, and identify apps that might be suitable to recommend to your clients. One of the apps that's on that software finder is Aphasia Therapy Online. And Aphasia Therapy Online is a free protocol, no sign up, no cost. It was designed by Dr. John Pierce, and as I said, it's free to use. So one of the lovely things about Aphasia Therapy Online is it's already been culturally and linguistically adapted into 11 different languages, and there are more coming. So that might be of particular interest to some of the participants on our webinar today who are working with people from different cultural linguistic backgrounds. And you can see here the kinds of tasks across reading, spelling, listening, naming, and that you can personalize the type of task and how easy and more difficult it is. And so I really recommend that resource to you as well. Another whole part of work in aphasia rehabilitation, taking into account environmental factors, would be communication partner training. And there are a range of communication partner training resources available to us now, thanks to the work of so many people around the world. Some of you would be well familiar with the Aphasia Institute in Canada that has a long history of developing and providing support for communication partner training. Their resources in general are really fabulous, but their long history in SCA, or supported conversation for adults with aphasia. They provide a free training program on this website if you go to their education and training link. There's also paid courses that you can do that are more in-depth. Another important communication partner training program source would be Aphasia Access, where you can learn some of the fundamental techniques through their fabulous education videos. I mentioned them previously. And in Australia, we have the wonderful interactability program developed by colleagues at Sydney University. And in this communication partner resource, the team were not just focusing on aphasia and stroke, but more broadly acquired brain injury. So it has applicability to people that you might be working with beyond stroke and aphasia. It's a freely available program. Takes about 2 hours to complete, and you might find that a really useful resource to explore. The Better Conversations with Aphasia is another wonderful, freely available resource, and this is focused not just on the basics of communication partner training, but morphing into conversation therapy. So for speech and language therapists to be able to carry out conversation therapy more with great skill and ability. So I recommend that to you very highly. And recently, Yoda Isaacson developed the Int'l program for communication partner training for health professionals specifically, and this was developed in Danish in Denmark. And that's a 2 by 3 hour session program. But I'd love to hear recently that they have undertaken work to culturally and linguistically adapt that into a range of languages and cultures. And I would recommend that you contact these authors to explore access to these materials. Okay, we're whipping through the resources. I hope you're not too exhausted. For those of you that are joining via the digital link later on, you'll be able to stop and replay. But for those of you that are online at the moment that are feeling like we've covered a lot, this will go up online and you'll be able to replay it at your leisure and perhaps get access to the resources that we're flicking past. So now I'd like to focus on the mood and wellbeing domain and in particular STEP psychological care. So it's a multidisciplinary model of care to address psychological problems after stroke and designed to be responsive to an individual's symptoms, recovery and needs. So here trained health professionals, and that's including speech pathologists, deliver mood screening, counselling and psychological therapy at lower, less intense levels of care, whereas trained mental health professionals deliver the psychological therapy at higher levels of care. So let's look and see what that means. So in this model, level 1, which would be a lower level, less intense level of care, is useful for people with sub-threshold problems in mood. For example, people that are not going to have a diagnosis of depression or anxiety on a screener or on a clinical examination, but are feeling poorly, feeling low, and are at risk for developing clinical diagnoses. Level 2 is for people that actually have a diagnosis, but at the mild to moderate level. Level 3 at the severe level, and level 4 severe, including challenging behaviours. So the idea is here that speech pathologists and other trained health professionals would deliver some interventions at this lower level 1 area. And the idea is that in delivering these in the context of a team, you're trying to prevent depression or other mental health conditions developing and generally support psychological well-being. And ideally, you would be supported by mental health professionals in the delivery. So let's look at one example of a level 1 intervention called Aphasia PRISM, which stands for Preventative Intervention and Support in Mental Health. And this work was led by Carolyn Baker and a team across the aphasia CRE. And this looks at 3 different modes, so behavioural activation, relaxation therapy, and problem-solving therapy. And these have been adapted by Carolyn and the team to be communicatively accessible and able to be delivered by a range of health professionals that might typically work in a stroke rehabilitation setting. Really fantastically, Caroline was responsible for drawing up the therapy program manual, which is a very rich and fabulous resource, so that if you were interested in carrying out these interventions in your team, you could go to that manual and use the resources that are sitting in it to be able to enact these therapies in your setting. So I thoroughly recommend you get access to that therapy program manual. Another example is at level 2. So these is when for clients that actually have a diagnosis of depression and anxiety, and this intervention is called ADAPT. And we know that cognitive behavioural therapy is a well-researched evidence-based intervention for depression and anxiety. But of course, being a talking-based therapy, it's very difficult to enact in aphasia. And so the team adapted this to have it more communicatively accessible, so with communicative accommodations included. And if you're interested in working with a psychologist or another mental health professional on being able to implement ADAPT, I recommend you go to that journal article and contact the authors to get access to those materials. Okay, the last sort of section we're going to talk about here to do directly with the person with aphasia is community aphasia groups and peer befriending. So some time ago here at La Trobe, we worked to develop a modular-based approach to developing group programs for people with aphasia. And the idea was to cover off a range of goals, so focusing on stroke and aphasia education, on communication skill building, on conversation activity, on psychological support, including direct work on identity renegotiation after aphasia and stroke, on social support, and on participation in activities that are found to be accessible and enjoyable for people with communication disability. And importantly, a module that's focused on the needs of carers and family. So we researched this modular approach in a couple of small trials and found it to be acceptable and feasible and showing preliminary efficacy. And because of that, working with speech pathology and mental health professionals and working with the community volunteers with and without aphasia who were helping to facilitate this group, we then developed resources to promote the use of this model elsewhere. So the model is called the Int'l CAG, which is a funny name, but it stands for Interdisciplinary Community Aphasia Group. And the facilitator program manual is available for free download on the aphasia community website. That's aphasia.community. So I really encourage you to look at that if you're considering developing a community aphasia group. But one of the challenges of the Int'l model is that, as I said before, it's a little bit expensive because you've got it facilitated by speech pathologists and mental health professionals. And we just know that's very difficult to scale up on a large scale just because of not having access to enough of these professionals to run the groups. So as a response to that, we then went on to develop the peer-led hub and spoke community aphasia group program. And in this program, we still have the same modular approach. So the idea that we run a range of modules that support a range of goals, and it's the participants with aphasia that work with the facilitator to define the program according to their needs and interests. So they might not want to do anything about identity, for example, but they want to spend a lot of time in these nonverbal participation activities and conversation. So it's modularized. It's up to the individual group to decide how they want to run it. But rather than having the speech pathologist and the psychologist or social worker run all of these groups, we developed this hub and spoke concept where a hub of health professionals are involved in setting up the opportunity for the groups to happen, but not actually facilitating them. Rather, the facilitation is carried out through people with and without aphasia, so volunteer trained facilitators. And in this model, then, the health professionals are responsible for referring patients, recruiting and training facilitators, supporting facilitators, and if need be, the kind of crisis management and referral that we often see needs to happen in groups over time that might start to fold, or there's particular members who need more support than the volunteer facilitators can manage. So this is an interesting model that we're currently exploring. There's been a phase 2 trial operating out here in Australia, led by Dr. Lucy Lanyon, and she's looking forward to giving you the full results of that shortly. But in the meantime, we've put up our implementation manual for the Hub and Spoke peer-led group, also up onto the aphasia community website. So please feel free to download that, and we hope the resources in that manual are useful for you to get groups going in your community. Peer befriending is another kind of support program where a person that's had the experience of living with communication disability goes and supports another person who perhaps is new to it or looking for more support. And Katerina Hillary from City University in the UK ran a phase 2 trial exploring peer befriending. The trial was called Superb, and found some really promising results in that trial. And if you follow the links to their website there, you'll find the publications and findings of that trial. But you could also make your way to the CARA resource hub that is on City University's website. And in there, you'll find lots of fabulous resources, and they're updating their resources quite regularly. And one of them is these series of videos they've done around supporting emotional recovery after aphasia. They're very high quality. I can imagine that people in many places around the world that can manage English will find these videos quite supportive and useful. And to sort of finish off on the resources part of this talk today, I want to talk about a couple of things that are coming soon. They're in field testing at the moment, and we look forward to letting you know that they're available very soon. And these are focused on carer support and education. So in Australia, we've had a 5-year project running called Communication Connect. And the idea of this is it's a web platform that hosts a range of resources to support people after discharge from hospital and rehabilitation processes. And those people are people with living with aphasia or communication disability after traumatic brain injury, and people that are caring for those people. But also there's resources in this site for health professionals who are trying to adjust their practice to improve access for people with communication disability. So a whole range of resources sit behind these 3 doors that you can see on the screen at the moment. But what I wanted to focus on as a sort of taster for what's coming is the resources for carers. And this is the work of Nelson Hernandez, who is a PhD student here in the aphasia CRE. So Nelson's developed a carer needs checklist, and the idea with the carer needs checklist is that the carer can go through a set of pretty simple questions to identify what is it that they need more assistance or information about to help them care for someone with communication disability, but also, really importantly, what they need to understand how better to care for their own needs, to care for themselves. And having carried out this checklist, they then are given a summary of the kinds of areas that they have said they need more information about. And then, because of the clever way that this website has been developed using AI and other algorithms, then the resources are tailored to their needs. So there's a whole range of resources sitting behind this page here. So one of the resources that we have co-designed with carers is the Closer program, carers looking after themselves and supporting aphasia. And again, a major piece of work led by Nelson Hernandez. And it's a self-paced e-learning interactive intervention for carers. And there are 3 modules. So one about adjusting to change after aphasia, one about supporting someone with aphasia, and then, as I said, very importantly, one about caring for themselves. And it's rather beautifully designed using lots of educational design methodology to make this a highly usable and motivating program. So we've got this in field testing at the moment. We've already had some nice feedback about it, but we will be able to say more about it very soon. Look forward to bringing this to the world. Okay, so I said that I'd talk to about for about 50 minutes, and we're almost there. Just to highlight that if this seminar has whet your appetite for learning about aphasia rehabilitation, there are many other places that you can get more information and education, and one of them is our Aphasia CRE YouTube site. So you'll see at the moment that we have 59 one-hour seminars loaded up onto the site, and these cover a huge range of topics led by experts in the field. And I'm sure if you go to our website and our YouTube channel and you have a look at the topics, there'll be things that you definitely want to go deeper into and follow up. So recommend that to you. Okay, so in summary, I've argued that a biopsychosocial model of care is absolutely essential, non-negotiable for aphasia rehabilitation because of the broad impacts of aphasia on areas. We've looked at the ICF as a way of thinking about those broad areas, and today we covered off on some resources that would help you enact interventions across the ICF. So I introduced you to the aphasia rehabilitation pathway, to the aphasia therapy finder, where you can find detailed information about how to do a range of therapies, to the aphasia software finder to look for self-management and apps to help do increased dose and intensity of interventions. We looked at the aphasia therapy online, so the free website. We looked at interactability as an example of communication partner training programs, tackling environmental issues in aphasia. I suggested the aphasia PRISM workbook as a way to understand how to tackle some of the low-level, level 1 preventative work in mood and well-being. And we focused on some community aphasia group resources, including the Int'l CAG manual and the Hub and Spoke manual. And finally, I gave you the teaser of what's coming down the track in terms of post-discharge support for people with aphasia, being Communication Connect. And all of these resources that we've touched on today are all about maximising communication ability and improving participation and quality of life for people living with aphasia and their family and friends. That's really the goal. So I hope that you found something useful in today's talk, and I'll stop sharing my screen in just a moment and see if there's some questions that we can address as well. Thank you so much for listening. Okay. Right, let's have a look at the Q&A. Right, looks like there's just one question online at the moment, and that is from Jody Laughlin, who's She said, comments on dosage of therapy 2 to 3 years post-stroke. Okay, so I think Jody is meaning she is questioning about whether these dosages that we were talking about with the work from release would still apply in people who are 2 to 3 years post-stroke. Thanks for that comment question, Jody. Absolutely. So in fact, a lot of the participants that were in the studies that were meta-analysed in the release work were people who were in the chronic phase of recovery. So these are people, more than 6 months post-stroke, but a lot of them were many years post-stroke. In some studies, people have been recruited, 10 to 15 years post-stroke. And in many of those studies, we're still able to see significant change after these higher doses of intervention, despite the fact that someone's so long post-stroke. So, yeah, I think the answer to the comment is that at this stage, the idea that we need a reasonably high dose and high intensity of intervention to see change is relevant, even in people with more chronic aphasia. Carol Taylor has made a comment, I think. She says, thank you so much. I'm in New Zealand and we are using a program called TACAS, Taking Charge of Your Life After Stroke. Have you heard of this? Yes, I have. Thank you so much, Carol. And thanks for raising it. Like I said, we couldn't cover off every resource that is available in the world at the moment, but the Taking Charge intervention has undergone a range of trials. And it's in general a single session intervention to help people after stroke focus on some goals that they would like to achieve to improve their well-being. So that looks like it's got some really important opportunity, and definitely encourage people to explore the Taking Charge intervention. Lorraine Vassilo has said, thank you for your most interesting and informative presentation, Miranda. Coming from bilingual aphasia focus, would you have any info to share about bilingual aphasia rehab and resources? Thank you so much, Lorraine. You're quite right that today this seminar has focused very much on sort of more monolingual aspects. A lot of the aphasia research has been done in English-speaking participants from English-speaking foci, and that's a limitation of the kind of resources and information that we have at the moment. There are, though, a lot of people around the world working hard to amend that bias that's in our research literature and in our resource development. And the collaboration of aphasia trialists, or CATS, is a website that you might like to go and have a look at and perhaps join if you're not already a member, Lorraine. There's many people within the collaboration of aphasia trialists who are working to adapt interventions across languages across the world, to work towards adapting interventions so that they can be implemented across cultural and linguistic groups. Thank you so much for that question. It's very, very important. Babalwa Ludidi says, thank you so much for a great presentation. I'm a therapist in South Africa and would really love to engage on the development or adaptation of some of the resources you presented for our context. Please assist with guidance as how to reach the authors. So thank you, Babala, for your interest. So if you want to reach out to me, you can just Google me, or you can look up Miranda Rose at La Trobe University to get my email address. Please go ahead and reach out, and I'll see if I can link you to people that of interest and topics that are of interest to you. Justine Hamilton, is communication similar to aphasia.ca in Canada? I'm not sure what aphasia.ca in Canada is, Justine. So if you want to go on and tell us a bit more about that in the comments, please, in the Q&A, please go ahead and do that. Kylie Bauer asks, for allied health students who are not speech pathologists working with aphasia, what would be your recommended online learning resources? The Communication Connect Health Professional Resources or a Communication Partner Training Program? Our context is a student-led community rehab program. Thanks, Kylie. Well, I'm going to think to start with getting the staff that are involved, students and staff that are involved who are not speech pathologists, to have at least basic communication partner training would be a fabulous place to start. And I would recommend that you look at the communication partner training resources that I mentioned today to see if they would work for your context, and to see if you can get engagement with your relevant program. Reaching out to someone like Jøda Isaacson at the University of Southern Denmark, who's done a lot of work in adapting Int'l for the broad range of health professionals would be good. The interactability site that I mentioned, which is at the University of Sydney, might also be really useful for you. Okay, we've got time, I think, for one more question before we call it quits today. And it's from Abigail Brooks. Thank you, great presentation. Wondering on any recommendations and advice regarding how to set up or maximize discussions for person-centered goal setting with a person with aphasia, rather than resorting to the priorities of staff and families. I find a lot of these discussions with the patients themselves end up being quite leading questions, given the limitations of their communication to contribute ideas, thoughts, feelings. That's a really great comment, Abigail. And I think the resource that I mentioned in terms of the free resource that's available through the Tactus Therapy website absolutely tries to tackle that challenge. With someone who has very limited communication ability, the feeling is that you are, giving a lot of leading questions and, if anything, putting words in people's mouths. But the idea is to, through that communicatively accessible process of presenting options and checking for understanding of those and making sure that the person with aphasia is actively indicating choice, I think we can overcome some of the challenges of having to resort, in your words, to staff and family preferences. And of course, this means that extra time is required in order to carry out that very person-centered goal setting with someone with communication disability. But I do recommend you think about those communication accessible resources to support the goal setting process. Okay, we need to call it quits. We're over the hour. I've really enjoyed the opportunity to pull this presentation together. I hope some of the resources that we've focused on today are of interest to you and that you'll follow up with them. And we will be, because this seminar's been recorded, we'll be placing that recording up on the IALP YouTube channel shortly, and we'll be able to email you out through your registration process to let you know that's happened and to link you up with that link. Thank you so much for your attention wherever you are in the world. I hope the rest of your day and night goes safely, and I hope you feel motivated to go forward and improve the communication practice that we have going in aphasia rehabilitation in the world. Thank you so much. Bye now.